So, good evening, welcome everyone. This is the webinar for workstream 3 within EUROGEN, rare urogenital disease. My name is Hans Langenhuijsen. I'm a urologist in Radboudumc in Nijmegen in the Netherlands. I would like to talk about the extent and the role of lymph node dissection in adrenal cortical cancer. So these are my potential conflicts of interest. So first of all, I'd like to introduce this disease. There's been previous webinars about the topic, but today specifically I will talk about lymph node dissection and the extent of lymph node dissection. So first something about surgical anatomy, and then about diagnosis, the evidence from the literature to perform lymph node dissection, and then future perspectives to come to my conclusions. So please feel free to use the Q&A button for questions. We'll have time available after the session to do live question and answering. So first of all, as you may well know, ACC is a really rare disease. So the incidence is about 1 in a million people, and presentation of patients is quite often with hormonal overproduction. This is often cortisol, so patients develop hypercortisolism called Cushing's syndrome, or have locally advanced disease and mass effects of the tumor, and it is quite often even incidentally found. So we know there's a genetic predisposition for ACC, especially in MEN1 syndrome, for instance, and the survival is rather poor. So in general, 5-year survival rates are about 35% in ACC, and this drops to less than 15% in metastatic disease, and for stage 3 disease that we talk about today, so with lymph node metastasis or local infiltration of the tumor, survival is about 50% after 5 years. So historically, open surgery is the way to go, and this is because many of these tumors are large tumors, so the median size is 10 to 11 centimeters. And surgery, really important, provides the only chance of cure. So ACC is not sensitive to chemotherapy or any other treatment. So in general, it's important to follow the oncological principles. So even if you do laparoscopy for ACC, you should do en bloc resection. So you should take out the adrenal together with this periadrenal fat. And that is because even in stage 2, so localized disease, we see quite a significant percentage of upstaging of the disease after surgery. And the paradigm is to do lymphadenectomy, at least of the periadrenal and renal hilum lymph nodes. So for advanced disease, locally advanced stage 3 with invasion in surrounding tissues or positive lymph nodes, you do open procedure classically, and it's really important to prevent spillage of tumor, especially macroscopic spillage, because you see a very high recurrence rate and a poor survival in patients who have tumor spillage. As you can see here, if you do a radical dissection, it's about 50% chance of recurrence, but it drops fast to 20% in microscopic positive margins, or even to 15% with macroscopic positive margins. So surgery is the key, and surgery is really important in treating this disease. So then really important also is the surgical anatomy. You know that the adrenals are retroperitoneal organs, and this means in advanced ACC surgery, so with the larger tumors, with lymph node dissection, you have to go to the retroperitoneum by transabdominal approach, because the tumor is too large to do an extraperitoneal approach, and this means that you have to put aside all the intraperitoneal organs, including liver, stomach, and intestines. Then the blood supply is really predictable. So both adrenals on both sides have multiple arteries, about 50 arteries running to the adrenal from 3 sides. So there's the superior arteries coming from the inferior phrenic artery. Then there's the medial ones directly from the aorta. And there's the inferior arteries running from the renal artery on both sides. Venous blood supply is also quite predictable. On the right side, there's a direct drainage of the adrenal vein into the caval vein. On the left side it drains into the renal vein, and there's about 5 to 10% accessory veins on both sides actually from different directions possible. So how about lymphatic drainage? Basically, as we also know from the textbooks, it's rather unknown how this lymphatic drainage is of both adrenals, but in general it's said in our textbooks that the para-aortal nodes, basically from the diaphragm down to the ipsilateral renal vein, are the ones that should be looked at. So basically you can see here the area of possible lymph nodes from adrenal tumors. So it's from the celiac trunk down to the superior mesenteric artery and down to the renal vein and artery as the caudal border of the lymph nodes. So if we look then at template, as you can see here from our vast experience with testicular cancer and retroperitoneal lymph node dissections in red, we have now the template here for adrenal surgery. So basically on the right side and on the left side you should start doing lymph node dissection from the celiac trunk down to the renal hilum minimally. And then we also know from our RPL&D surgery that it has certain complications, specifically in men who get retrograde ejaculation by injury to the sympathetic nerve. So basically when you go over the aorta or interaortal cavity, there's a chance of damage to the sympathetic chain and you have retrograde ejaculation. And in adrenal surgery, in general, the complication rate is similar to that surgery for testicular cancer. So something to consider when you consider extended lymph node dissection. This is a really important and very interesting paper. In this study, they have looked at the recurrences after ACC surgery in lymph nodes. So this is after removing the primary tumor. And on the left side, you can see here that it's quite predictable that in the renal hilum, most of the times the recurrences occur, but also for left ACCs, you see that interaorticavally lymph nodes are metastasized in about 20% of the cases. Similar finding for right ACCs, as you can see here on the slide, it's about 35% of interaortocaval lymph nodes found after surgery for ACC, and specifically remarkable, in about 10% of cases for right ACCs, there's sort of a crossover of lymph nodes affected by the disease to the left side, so left para-aortic lymph nodes, a bit similar like in testicular cancer. So these are quite substantial percentages of lymph nodes outside the template I just showed you. So in fact we should consider doing an extended lymph node dissection. So for the right hand side, that would mean that you go from the celiac trunk downwards, maybe even down to the inferior mesenteric artery, and do a interaortocaval lymph node dissection, probably cross the aorta boundary on the left side as well. And for the left-sided ACCs, as you can see here in the image, similar template but then reversed, so all the way down from the diaphragm to the inferior mesenteric artery. So this would mean open surgery, obviously, the way we do it in RPL&Ds, and you get the best exposure of the retroperitoneum by doing a transabdominal approach, major surgery, but you will be able to clear all the para-aortal, interaortal caval lymph nodes quite sufficiently. How about diagnostics? How do we know for sure this is an ACC, which is important for operation planning? As you may know from my other webinars, we do not advocate biopsies of ACCs. Why? Because it's such an aggressive disease and we're really afraid of spillage when we biopsy ACC. So basically it is not allowed to do biopsies in ACC suspicion, so we have to rely completely on our imaging and on our biochemical assessment. Then again, we assess the cortisol levels, as we quite often see Cushing in ACC patients, and this is also a prognostic factor in ACC. And further, we quite often see virilization of the patient based on testosterone rise levels, for instance DHEAS and testosterone. So these are important to assess beforehand to get an estimation of the chance of an ACC. And then obviously imaging is really important, so you do a CT scan with IV contrast. And we know from our studies that without contrast, or the non-enhanced phase of these tumors, there's quite a high Hounsfield unit, above 10. And these tumors typically have this very heterogeneous aspect. They quite often have central necrosis and then peripheral rim enhancement after you give IV contrast. And the washout of this contrast is also too low. So how about lymph nodes? We know that CT has a high sensitivity to detect lymph node metastasis. Obviously, that's something you like to know and you like to have, but the specificity is much lower for CT scan, something you have to consider. And then other findings on diagnostics is vascular invasion. So it's about 20% of the cases, and this can indicate you that it is truly an ACC and not a benign large tumor. So we found about 30% of synchronous metastasis as well, which is also obviously indication for a malignant tumor. Then quite often we perform MRI. This is basically to see whether the ingrowth of the thrombus is in the vein, and we perform FDG PET scanning to find distant metastasis, but also in the follow-up. So when we look at incidentaloma, any incidental finding of a tumor, we have to rely on these three aspects. So size is something important. If you consider that smaller tumors below 4 centimeters hardly ever are ACCs, but the larger ones above 6 centimeters are quite often ACC. And then we have to rely on our radiological appearance, as mentioned before, and on hormone evaluation. So these are the three pillars that indicate whether the chance for ACC is high and can help you with your surgical planning and the planning of lymph node dissection. So then we use the NSAT stage criteria. Basically, localized disease are NSAT stage 1 and 2 with a cutoff of 5 centimeters, and stage 3 are ACCs that are locally advanced, so invasion of surrounding tissue and or positive lymph nodes on imaging, and stage 4 is metastasized ACC. So what evidence do we have in the literature to perform lymph node dissection? From our own group, we published this review meta-analysis in 2016, and from the different studies that we evaluated, we found that it's really important to have the surgeon report whether he did a lymph node dissection after surgery in a surgical report. It's one of the quality criteria that are important. It's also important for the pathologist to report whether he finds that more than 5 lymph nodes have been removed. So in our systematic review, we found no difference in time to progression, time to recurrence, or recurrence rates after lymph node dissection. That is in general, but for the histologically proven positive lymph nodes, we found a shorter time to recurrence when a proper lymph node dissection was not performed. So again, preoperative staging with imaging is really important. And then there was a trend for better recurrence-free survival in NSAT stage 3 disease, but no survival improvement has been shown. And in localized disease, so NSAT stage 2, it is still unclear what the role of lymph node dissection is. It probably mainly has a diagnostic value. And then from a consensus meeting we had in 2014 in Paris, we found several interesting findings that formal lymph node dissection is really hardly ever performed by surgeons, something to bear in mind. And also accurately assessment by pathologists is lacking. There's a clear plea to improve these findings. They have found an interesting study from Germany, and there was a suggestion in this study that there was a reduced risk for local recurrence and disease-specific death after resection of at least 5 lymph nodes. And altogether, they found a more accurate staging of the disease with a formal lymph node dissection, but the influence of this lymph node dissection on disease-free survival and overall survival was conflicting and still uncertain from this consensus meeting. So I looked at the more recent data in the literature. I'll give you an overview, and you have to know that there's very limited evidence in the literature. There's only about 115 hits when you look for lymph node dissection and ACC. These are all retrospective studies in case series, but basically the conclusions of the more recent literature is that very few patients get a lymph node dissection with adrenal cortical carcinoma, up to 16% maximally. And this depends on the disease stage, the size of the tumor, and the extra-adrenal extension on imaging, and the fact whether open surgery is performed. This predicts that lymph node dissection is being performed. And of those in which lymph node dissection is performed, about 30% have positive nodes. So we found that these patients with positive nodes indeed have an association with extra-adrenal extension. And if more than 1 positive nodes are found, this predicts cancer-specific survival. And it incrementally worsens the survival if more positive nodes are found. And disappointingly, the lymph node harvest, regardless of the number of nodes that was removed, is really not associated with survival, although there's one study seen here that did show a survival gain for proper lymph node dissection, but it's not quite sure from this study whether this is because positive nodes were removed or whether it was a prophylactic effect of negative nodes being removed, or maybe in fact it's just better surgery. The surgeons who do formal lymph node dissection may be better in removing a tumor radically. We just don't know which one of these 3 is the factor that influenced survival in that series. It is important not to know, though, that the high-grade complications are similar, whether a lymph node dissection is performed or not. Obviously, that is important in your consideration to do an extended lymph node dissection. So then the last but very recent systematic review meta-analysis comes from this group, and they found again some conflicting results, as you can see in the red underlined lines, that several studies in stage 1 to 3 ACC revealed a survival benefit after lymph node dissection, but other studies in which mostly stage 1 to 4 patients were included, they did not find a survival benefit. So still conflicting evidence, but at the end these authors conclude that in localized disease, they call it stage 1 to 3, lymphadenectomy could offer oncological benefit, although if you're honest, stage 3 is not a localized tumor anymore, but it is locally progressed. So I brought you this case of a patient that we saw in 2020, 60-year-old female patient. She presented with abdominal pain complaints and weight loss, and we suspected her of intra-abdominal tumor, did imaging and also biochemical screening, and we did not find high cortisol, but we did find high androgens, so DHEAS, testosterone and androstenedione were elevated, and this patient also had signs of viralization. So on CT scan we found a left adrenal tumor, and we decided to do FDG PET scanning to look for metastasis, and here you can see the imaging, and you see this typical appearance of the left ACC with central necrosis, and there's clearly after contrast a peripheral rim enhancement, such a typical image of ACC. And you can see that image on the PET CT scan as well, so the central necrosis. We did not find any metastasis, and we did not find any lymph nodes suspicious of lymph node metastasis. So this is considered urgent indication for operation. So the operation was done within 2 weeks, and we performed an open en bloc resection of the left adrenal, including the kidney, of which we suspected there would be ingrowth, and we performed a formal hilar lymph node dissection of the renal hilum. There was a complication during surgery of a diaphragm tear, and this was corrected during operation and uneventfully resolved after a recovery. So then the pathologist informed us that he found adrenal cortical cancer, according to the Weiss criteria, and it was 15 centimeters in diameter, and quite surprisingly it was still end-stage stage 2, so it was a localized tumor. The kidney was displaced, there was no invasion of the kidney, and there were no positive lymph nodes found and a negative resection margin. And then proliferation index was quite low, so it decided in a multidisciplinary team that there was no indication for adjuvant mitotain treatment. But I have to be critical about this pathology report, because if you dig into the report, you don't see any positive lymph nodes, but in fact the pathologist does not describe the lymph nodes. So either he didn't find them, either he didn't report them, and definitely didn't count them. And we have to be critical and go back to our pathologist that we need this information. We need to know, have 5 lymph nodes been removed or not? And this is also something for ourselves as surgeons. We should be clear after surgery, do you want to have this information from your pathologist about the lymph node status? And I think that's really important. So then the future perspectives. So we know that training of surgeons and high volume has a positive effect on morbidity and survival, let's say in general, and that ACC is considered surgery for high expertise centers. So from negative surgical margins, we know this number increases in higher caseload. And in the consensus meeting back in 2014, we considered more than 15 adrenal operations per year, let's say the minimum. So there's also a positive outcome when you work in multidisciplinary teams. I'd like to stress this, really important. And you have to have your vascular surgeon or liver or pancreas surgeon in the operating theater if you get very high, if you have very high and complex large tumors. So the preoperative multidisciplinary discussion is really important, as I showed, because of the biochemical assessment and the imaging. So what are, in my opinion, future developments? In fact, it might be that robotics has a place for the future. Until now, the larger tumors are all operated open, and as you saw in the literature, not quite often a formal lymph node dissection is performed. So it might be that robotics may help us to do a better job, and it's definitely, to my opinion, something we should look into, what the extra role is for robotics in ACC surgery. And as I said already, the only chance of cure is a proper surgical operation, and that has to be taken in account. And then there might be a place for better imaging. In fact, we don't know the drainage of lymphatics at all, so there could be an indication for better surgery with fluorescence. Maybe, first of all, to find the sentinel node and to see what the distribution of lymphatics around the adrenals really is, because there's no publication about this topic, and this could definitely help us further for imaging and for staging disease preoperatively. So I believe there's definitely a place for EUROGEN for this topic. As I said, the incidence is extremely rare, so we need large patient numbers. And not only from our registries, we'll get the prospective data of our operated patients, really important to follow up with long-term follow-up, but also there's new opportunities within EUROGEN to do research together, because such rare disease, we need much more patients to be included in studies, for instance in imaging studies, to see how we can improve our final oncological outcome. Okay, so I'd like to come to my take-home messages. So I hope I've shown you that I believe in ACC surgery to be a multidisciplinary effort. It's really important to have a dedicated radiologist and pathologist, and also endocrinologist for your hormonal assessment for better surgical planning. In locally advanced disease, so NSAID stage 3, at least do a periadrenal and a renal hilum lymph node dissection, and even consider doing extended lymph node dissection as I showed you with the templates, and that is at this stage still all by open surgery. So we do have to consider that the local recurrence rate is lower after resection of positive lymph nodes. So again, preoperative imaging is really important. But if not only local recurrence rate reduction, it is also to prevent secondary surgery, because as we know, if you have to go back to resect a local recurrence after previous retroperitoneal surgery, this is extremely difficult surgery. We have to be honest, the impact on survival is still unclear. And for localized disease, so stage 1 and 2, the effect of prophylactic lymph node dissections of negative nodes is also unknown and should, in my opinion, not be the standard. So I mentioned future research and especially clinical evaluation in our registries in EUROGEN context is really important, and I believe that will help us further to estimate the role of a lymph node dissection and its extent, which has probably a major impact on outcome for patients in the future. So I'd like to thank you for your attention. I'd like to invite you to the Q&A session, and hopefully I'll be able to reflect on your questions, and hope to see you soon all. Thank you very much. Bye-bye.
Yes, thank you very much for the interesting talk. Thank you everyone for joining us. Please let us know if you have any questions, type them via the question field. Until now, we have not received any questions. So I'll start with telling you that the webinar has been recorded and will be available on both our GoToWebinar platform and a YouTube channel. And I will send the links tomorrow. All links for the previous sessions are on our website, as are the details of the forthcoming webinars. You can also subscribe to our YouTube channel. Finally, all of you who have attended today will receive a survey immediately after the webinar finished. And we would be grateful if you could spend a few minutes filling it in to help us continuously improve further sessions. I still have not received any questions. I'll just wait a few more minutes. So please, if you have any questions, type them in. Well, if there are no further questions, I would like to thank Hans for the very interesting talk. And I would like to thank all the attendees and wish you all a very good night. Thank you very much.
Thank you, Luz. Thank you, everyone, for watching.